Good morning, everybody. Welcome back. I'm so happy to be with you today. Today, we'll talk about future treatment of shock. We'll talk about a new idea for the management of shock patient. I believe would be very helpful in the future, and I tried in tens of cases, and it works. A 53 years old male patient, known case of sickle cell disease, ischemic dilated cardiomyopathy, obstructive uropathy due to BPH, which is treated in ER by suprapubic catheter because of urine retention. After that, the patient admitted to our ICU because of hypotension, desaturation, hematuria, and impaired renal function. We start our protocol of critical care ultrasound for shock. We have a very precise step-by-step approach protocol for a shocked patient you can review in our channels. First, we used to start by inferior vena cava. Here is the inferior vena cava of the patient. Too narrow for a patient with ischemic dilated cardiomyopathy. So, according to our protocol, if the inferior vena cava is too narrow, collapsing, we should search for sepsis as an element of shock and hypovolemia as an element of shock. In our patient, we search for blood loss site, probably in the bladder. Here is the bladder of our patient, full of turbid blood, most probably turbid fluid, most probably blood, with a catheter. There is a clots around the catheter and the clots here, and there is hematuria. So, the bladder is the source of blood loss in this patient. What else? We look to the heart to get any cardiac element of shock and to assess the wedge pressure for a shocked patient to follow in the management later on. Here is the heart of our patient. This is a 5-chamber view. You see here, it's 20% ejection fraction by visual assessment. It is ischemic dilated cardiomyopathy. What is the diastolic function? Grade 1 diastolic dysfunction, A wave less than E wave, and this denote no much rise of wedge pressure. What else? The patient is desaturated despite low wedge pressure and the narrow collapsing inferior vena cava. So, according to our protocol for management of dyspneic and oxygen desaturated patient, we have a very clear step-by-step approach for desaturated patient in our channel. You can review. According to this protocol, if we find a narrow inferior vena cava and low wedge pressure in dyspneic desaturated patient, we should explore a lung as a cause of dyspnea and desaturation. Here is the lung of the patient. Lower lobes, a lot of dirty pleura, subpleural consolidations, B-line, sick pleura, going with chest infection. So, fitting the bundle together, this patient has a mixed type of shock. Cardiogenic, septic, probably chest infection, hypovolemic because of blood loss from the bladder, which affect vital organs. The patient is on immunosuppressors, and there is rise of serum creatinine. What is the management? According to our protocol, we give proper immunosuppressor according to the ultrasound image. In this patient, noradrenaline and dolutegravir, and we give proper IV fluids, which is a watched IV fluids. We give IV fluids which is watched. We give IV fluids which is increasing the stroke volume and not causing pulmonary edema, and treatment of the cause. For this patient, treatment of the cause, we call urology for the hematuria, and we give antibiotic for chest infections. Immunosuppressors already started. What about proper IV fluids? Let us see. We usually use to assess, according to our protocol, we usually to assess the VTI at the beginning, which is 11.6. This VTI is a surrogate of stroke volume. We keep going blood and IV fluids as long as this VTI is increasing by 12 to 15%. After the VTI no more increasing by this percentage, we stop giving IV fluids. In this patient, we reach it to 22.85. Good. We almost double the stroke volume in this patient. We almost double the VTI in this patient. After that, no more increase and no more fluids. So we give the proper IV fluids in our patient. We follow also the diastolic function as a guide of two-way pressure in our patient, as a guide to giving IV fluids. In this patient, we keep going IV fluids until we reach it. Almost we go to grade 2 diastolic function. You see here, A wave start to get up. That means patient start to be filled by IV fluids. What else? Inferior vena cava in our patient start to open with IV fluids. Let's compare between before and after proper IV fluids. So, the best known management of shock is controlled best IV fluids. I will see you how the difference between pre and after IV fluids and treatment of the cause we talk about. You see here is, sorry, you see here is the inferior vena cava before and here is after. Here is before and here is after, start to fill up. You see here the VTI before 11, after 22. You see here the diastolic function. It was grade 1, increased to grade 2, and going to grade 2. What is the new? I talk about new ideas about treatment of shock. Really, I did this and it became a second nature of our management of shock in our hospital. Let us see. The question is, does the improvement in stroke volume match the improvement of perfusion of vital vascular bed? Okay, we are following the VTI as a surrogate of stroke volume. We are following the systolic pressure variation, pulse pressure variation, whatever. But the question is this rise of stroke volume is matching the perfusion of vital vascular organ, which is the goal of our treatment of shock, which is the goal, really the real goal. So, do we have an ultrasound way to get a good information about vital vascular bed? So the future treatment of shock will be looking for the vital vascular bed, the vascular bed of the vital organ, and knowing if there is improvement in perfusion on the cellular level, on the vital organ level or not. Yes, we have. Very easy to explore it. The Doppler study of renal arteries and TCD. And we can include other vascular bed later on. But renal vascular bed and transcranial Doppler is very important in management of shock patient. Let us see. Back to our patient. Usually, with shocked patient, you will see this. When you fire the color Doppler in the kidney, you will see this feeble, subtle flow. This very poor Doppler flow, which is in red in arterial system and the blue in the venous system, because my probe is here. The arterial stores my probe. You will keep giving fluids and watching the vascular bed improved by looking at the improvement of the color flow of the vital organs. It's very easy. Just you will put the probe to get abdominal probe to get the kidney, and you will fire the color Doppler, and you will follow as long as you are giving IV fluids. You will follow. What else? There is what's called resistive index, resistivity index or pulsatility index in this vital vascular bed. It is very easy to get. Once you get a color flow, you will get any artery in the kidney, whatever, segmental, interlobular, arcuate, any vascular bed in the kidney. You will put the pulsed wave Doppler in this red artery, and you will fire the pulsed wave Doppler. Will give you the peak systolic velocity and the end diastolic velocity. And the machine the machine will calculate the index, as RI, resistivity index, which is peak systolic minus end diastolic over peak systolic. This index, fortunately, and the very good news, is not relying on the angle. So you can put whatever the angle in the kidney, you can put the sample volume, whatever the angle, and the resistivity index will be the same. Okay, and you will follow this resistivity index. This RI usually in shocked patient, in fluid, in low perfusion state, severe low perfusion state, usually RI would be high and would be more than 0.75. So in this patient before treatment, the RI was 0.83 because there is high resistance in the vascular bed. It is vital vascular bed. After giving fluids, the RI start to decrease, and you can follow with IV fluids until even to normalization of the RI, and this you will be sure by this way that the vital organ is improving, and this is the best treatment of shock. This situation in the right kidney. Here you see here after treatment it's 0.72, and before treatment it was 0.8. There is, now I'm happy that my IV fluid is going in the right way, vital vascular bed. I have tens of cases, and I will be very happy if anyone is interested to do multi-center study approaching this point, approaching the Doppler study of the vital organ in shocked patient with follow-up IV fluids. I would be very happy if anyone contact me on my email to do this multi-central prospective study. I have tens of cases really. It became a second nature since a few months. This patient improved a lot, and we need from inoperator and discharge from ICU in very good shape. There is a reference about that, talk about this Doppler study. As you see here in this article, ultrasound and Doppler, you can give an effective resistance in differential diagnosis of acute renal failure. RI more than 0.75 is reported as optimal attempted differentiation between acute tubular necrosis and the renal failure. That means increasing RI denoting severe hypoperfusion in the patient. But no one follow up the RI with the management really. I didn't get any article about that. Here you are talking about most renal acute injury patient show it normal parenchymal vascular bed with RI less than 0.7. Whereas those with acute kidney injury due to acute tubular necrosis have a reduced parenchymal perfusion accompanied by elevated RI values, superior to any evidence of abnormal value of creatinine. So, exploring the vascular bed of vital organ will be very early on to detect the complaint of vascular organ before even rise of creatinine or other parameters or oliguria. Follow up the patient with both renal and pre-renal acute kidney injury by serial monitoring of RI during medical treatment of acute kidney injury show a progressive reduction and ultimately the normalization of RI value of renal parenchymal vessel and often perceive the return to normal function. I believe this would be the future of treatment of shock, and as I said, it is easy. It is not a complicated issue. It is only you put the probe and you will get the color. Very easy to get the color, and can master the degree of color flow. And once putting the pulsed wave Doppler, you can very easy to get RI or PI, and the machine will calculate. I am waiting for any response for this project to be done in a shocked patient ICU in a large scale, and I will be happy to hear from you. And at the end, thank you a lot for your appreciated listening. See you in another complete story and in another critical care ultrasound for seniors.